who will be discussing the surgical aspects of kidney transplantation and complications. Thanks a lot, Chinas. You can start.
Thank you, Sam. And from my side, thanks for the invitation to be part of this very good program that you're running in terms of registrar education. We've got a slight logistical issue this morning, so I'm going to start first with my presentation, and Fiona will follow with regards to the living and deceased donation aspects that you asked us to discuss. So I'm a general surgeon working at McCurdie in the transplant unit. Let me just quickly see if I can move one of my slides. Let's just go into, that's good. So I just wanted to start with this slide. Fiona will mostly discuss organ donation, but I thought I'll show this slide just to give you a kind of a summary of all the solid organ transplants being performed worldwide. This is from the Global Observatory on Donation and Transplantation. So it's the biggest WHO endorsed registry, and over 100,000 kidneys were estimated to be transplanted in 2019, obviously just pre-COVID. What I want to highlight in this slide is the fact that they estimate that less than 10% of the global needs are met, and more than a third of the kidney transplants are still being performed from living donors. Obviously, in principle, if we had enough deceased donors, then we would not need to do living donation at all. So there are some measures or mechanisms to try and expand the deceased donor pool. And we will touch on most of them quite briefly during the presentation. So machine perfusion is something that's on the horizon. We are quite hopeful that in the next 6 months, even within this year, that we will be able to get access to hyperthermic machine perfusion for kidney for very selected kidneys from deceased donors, and we'll talk a little bit about that in detail, or bit more in detail a bit later. Then en bloc kidney transplants, dual kidney transplants, which we've never done, and I don't think we will ever do. Then ECD stands for extended criteria donors. So when we look at the quality of deceased donor kidney, one can potentially divide it into standard criteria donors and extended criteria donors. The extended criteria donors are usually the patients who are older, so older than 60 or older than 50, with one of either they must be hypertensive or they must have a creatinine that's not normal. Usually that cutoff is around about 200. Yeah, so that's how we basically select those patients. Then we will talk a little bit about DCD in a bit more detail later on. And then one of the previous transplantations or surgeons at McCurdie, Almi Miller, who I'm sure you know, or still has a very good HIV to HIV positive program, where HIV positive donors are utilized and transplanted into selected HIV positive recipients. So over the last, well, from 2007, we had to think of strategies to expand the deceased donor pool. For us, those were using donors of the circulatory death, HIV positive donors, and extended criteria donors. And you can see over the last 13 years, 10 years, 13 years, how big a difference that made to the number of kidney transplants that we could actually do at McCurdie. Otherwise, there's a real significant downward trend in the number of donors. So on deceased donation, every once in a while, we get to fly in private planes, and it's actually quite, it makes you feel quite important. And when a transplant works, everyone is happy, but it's not, it's not always how things work out. And every once in a while, the complications can really get to you. But I'll just talk you through the deceased donor procurement, because I do think it's relevant, even if the talk is about kidney transplantation. So our approach, because we procure multi-organs at one time from an abdominal point of view, to include liver, sometimes pancreas or small bowel potentially, our approach is to get control of blood vessels, the main blood vessels, so common iliacs, and then the supraceliac aorta, and then the IVC. We have to divide, so we keep everything on block. It's a very kind of a more, we just want to remove the organ safely, keep all the anatomical bits, in continuity with the organ, and give ourselves as many options to transplant these kidneys as we can. So I just want to get back to this one. So the SMA, between the SMA and the renal arteries, that is the very important area where we need to divide the renal and the liver block very carefully, because there can be arterial anomalies that come off or originate from the SMA, which needs to go with the liver block. So this is a very important area. So the SMA will go with the liver block, and the renal arteries will stay with the kidney block. And the aorta that we take with the kidney block will be from just below the SMA all the way down to where our cannula is in. So this is a close-up picture. IVC, aorta common iliac, that's the aorta that's controlled in an umbilical tape. That is the SMA, and you can see the inferior pole of the two kidneys. So that is what we try and do. So after the cannula has been inserted in the common iliac artery, we heparinize the patient, we cross-clamp supraceliac, and we start flushing the kidneys with custodial. The kidneys are then brought to the midline, mobilized to the midline, and pulled, kind of off the vertebral column, and all the adhesions, lumbar arteries, and so it's basically dissected off the psoas muscle and the lumbar vertebra, while the kidneys are pulled to the midline. So they're removed en bloc. You can still see the aortic cannula in the common iliac or in the aorta there. We split them down the middle and then make sure that there are no accessory arteries, and we package them into the cooler boxes, and they are transported. So living donor nephrectomy, this is a whole different beast. It's something that it really is something that still makes us quite nervous, doing an operation on someone that doesn't really need it, and it needs to be 100% every time. So open donor nephrectomy, although we've moved away from it, is something that, there's definitely nothing wrong with it. For a selected patient, we potentially leave that option open, especially on the right side where a renal vein might be very short. There are certainly cases that we would take on with an open nephrectomy that we wouldn't with laparoscopic donor nephrectomy. So it leaves us an extra way of making a transplant happen. This is not what we're going for here. These are patients who were part of illegal activity, donated kidneys, and there are actually some reports that in some of the rural areas of Pakistan, about 40% of the adults have donated a kidney, which is it's incredible to hear. It's really shocking. But this is more the procedure or the outcome that we are going for in terms of cosmesis with the open nephrectomy. So everyone does the donor nephrectomies a little bit differently. What we do is a supraumbilical incision, pneumoperitoneum. We have a quick look around in terms of the diagnostic, just a diagnostic look around, make sure that there is no contraindication to proceeding. We incise, we do the fan and steel incision first. It's kind of a small fan and steel where we can fit a hand port into, and then we place our 2 working ports. It's important that this port is a 12 mil port because our stapler does not go through anything smaller. This usually will be a 5 mil port. And we rotate the colon off the kidney. Usually we work from the bottom up. So we look for gonadal, ureter. We sling with elastics and so that we can see them intraoperatively and control them a bit better. And then we work our way up to the vessels in the right plane. Usually we would mobilize and control the left renal vein first, or the renal vein first, and then followed by the artery. We obviously take the ureter, then we staple the renal artery first, followed by the renal vein. We prefer to use staplers where it's a non-cutting stapler with a staple line only on the one side, so on the donor side, and then we prefer to cut ourselves to maintain a little bit more vessel length to facilitate the transplant. So even if it's about 3 millimeters, that sometimes can make a bit of a difference. The staplers have now been discontinued, so we are kind of forced to look at other alternatives, and so far it's been working quite fine using those. I want to talk about recipient selection just very briefly. I think this is applicable to not only kidneys, but any solid organ that you're transplanting. You want to select those who will benefit the most from the transplant, who will have the best chance of post-op recovery and long-term survival. Long-term survival because we want them to actually, get good years out of the precious resource that they've been given, and they have to value and take care of this precious resource. And there are several ethical principles that I'm sure you know quite well that we have to try and balance. It's not always that easy in transplantation. So we want to balance utility, justice, autonomy, irrespective of race, gender, and socioeconomic status. That is the ultimate goal when we look at these things. So there are certain prerequisites for successful kidney transplant. We just mentioned, you have to have a fit patient, not only for the anesthetic, but to make use of the resource. They have to be immunologically compatible. All I'll say on that, because it's a more surgical talk, is that there are, the immunology around it, and it's becoming more and more advanced, and it is a massive part of having a successful kidney transplant program. So the only real contraindication at this time is a positive T-cell CDC cross-match. But the more risk you take immunologically, obviously the in a bigger group, the less the outcomes will be over time. So, but CDC cross-match, a T-cell CDC cross-match is positive. That's the only absolute contraindication to transplantation from an immunological point of view. So I'll just quickly run you through a video of a kidney transplant. It's a cartoon, obviously. So our incision is a Rutherford-Morrison incision. So we try and preserve that rectus. And so inferior epigastric vessels that we usually tie off if we know that we don't have a small vascular anastomosis that we'll have to use that as inflow. And we do that just to get more space to get to the bladder. So we perform the venous anastomosis first. And there are different ways of doing it, but we prefer to flip the kidney back and forth and do the two anastomoses from different sides. In this video, it's mostly done just from the one side. That's our arterial punch that we use. So this is for a living donor transplant. That's the big difference between living donor and deceased donor, is that we don't have a Corral patch to use from the donor aorta. Kidney's pinking up. The ureter goes underneath the spermatic cord. Sorry, that looks like it might be spermatic cord. We do it over a stent. We'll get to that a bit later. And we try and reproduce some form of an anti-reflux procedure. So we do a leash Gregoire. Okay, so the other four aspects would be: you want sufficient parenchymal mass and function, you want adequate arterial inflow and adequate outflow, venous outflow, and urinary tract continuity. So with regards to the quality of the kidney, hypothermic machine perfusion is something that's been around for a very long time, and it was last published, it was actually first published in 1975 in the Lancet. But it was expensive, it was logistically a bit difficult, and static cold storage, which is the storage of a kidney within a specially designed preservation solution, has worked so well. It was so cheap and it was so risk-free that, you know, that is what we are still doing today. It's the gold standard. There seems to be a bit of a momentum shift back towards machine perfusion for specific situations. And they are mostly selected kidneys who have had some ischemic damage, where you're uncertain of the chronicity of the disease, and where you do not want to risk implanting those kidneys into a recipient at that time. And machine perfusion can be to preserve a kidney for a longer period of time, but mostly to resuscitate it. And there's a lot of studies looking at how do we now assess the viability of this kidney now that we've perfused it on a machine perfusion device. Can we safely transplant it? And that is now the holy grail of machine perfusion in terms of deciding which cases should actually be done. This is an example of a kidney that we had to discard actually just a week or two ago. We did the whole procurement on the back table before the recipient. We could see lots of small petechial hemorrhages, and the background of the kidney was not the usual gray brownish color that we see. It was very, you know, it looked like it didn't flush properly. And when we flushed it on the back table, it was very slow. When I say slow, you know, despite putting quite a bit of pressure through the arterial system, there was only a little bit of perfusion fluid coming out through the venous system, and only with quite a lot of pressure. So we decided to discard it, but this would have been the ideal kidney to see if you know, it would improve on a machine perfusion device. This is a little video of an experimental model of a kidney getting perfused. This is obviously a normothermic model. You can see kidney is nice and pink, very happy, passing urine. So for selected deceased donor kidneys, this certainly is something that will make a big difference in future. Very rarely do we struggle with the fact that, you know, we do not have enough parenchyma. So any donor below 18 years old would be allocated to a Red Cross recipient, a pediatric recipient. And from time to time, we might not have a suitable pediatric recipient for kidneys. So it is possible to implant en bloc kidneys into a slightly larger individual, a larger child, or even an adult. We've only performed one of these years ago. So it's not a common situation, but from a technical point of view, it certainly can be done. So let me just go back there. Adequate arterial inflow is obviously very important, as the renal arteries are end arteries, and we quite often sit with a situation where we have multiple arteries. So this is an example, probably extreme example of the type of arterial anatomical anomalies that we see, and that is why it's so important to do the deceased donor like you would, you know, like I showed you, to get control of the major vessels and keep it on block with the aorta all the way down, split the aorta in the middle. Otherwise, all these vessels, if you approach it like a normal nephrectomy, you're going to miss out on quite a few of these vessels. And you don't have any imaging in the deceased donor beforehand, so you don't know of these vessels. And that is a picture of it being transplanted onto one chorale patch onto the external iliac artery. Now, this is another example where we had those two inferior polar vessels or accessory vessels, where the distance was just too far to get it onto one patch. So we made two patches, two separate patches, one for the main artery and one for the two others, and transplanted it like this. You can see this is the main artery, the chorale patch, two inferior ones, and then the renal vein in between and behind it. This is a small polar vessel that was not identified at deceased donor procurement. You can see the rest of the kidney has already been perfused, looks nice and pink. And there's a large area that's bluish discoloration. The pale area is just like that because I tried to flush it. Our only option here would be to take one of the inferior epigastric arteries and try and sew to that. If it's a superior polar vessel, we'll just ligate it and accept that, you know, that part of the kidney is not going to perfuse. If it's an inferior vessel, then because of the blood supply of the ureter, we need to make a plan. And that would usually be flipping one of the inferior epigastric arteries across and doing a very small anastomosis onto that vessel. So this is a CTA of one of the recent living donors that were referred to us. And you can see that, you know, as I mentioned, you cannot take a chorale patch in a living donor. So you have to really think carefully. Yeah. There we go. So on the left, we've got 3 renal arteries coming off, originating off the aorta. That would entail, you know, very small anastomosis, 3.5 millimeters with arterial punch, all at risk of thrombosis. On the right, we've got a single renal artery, but with a kind of an early bifurcation. The IVC, I know that's not a venous face, but it actually came in behind the IVC. So we tried to just mobilize the IVC very slightly, but we couldn't get to the right in this area. This was the focus area where we wanted to work, and the kidney had to be mobilized completely and flipped medially, and we had to approach the artery from the back, if you will. But everything went well, but this is one of the more complex decisions that you come across living donor. So we like to use aspirin. I'm not going to take you through all the details of the study. You're welcome to go back and read it as a reference. Aspirin really does give us some protective mechanisms against renal artery thrombosis, especially in the living donor groups. And it's a small dose, so we give 150 milligrams of aspirin for the first 5 days, and after first 3 days, and then after that we would discontinue it. We feel that the highest risk period for renal artery thrombosis would be in that first 3 days, if not the first 24 hours. And our renal physicians get a bit edgy by day 3, day 4, because usually at about day 6 or 7, if they need to biopsy, that would be the time, and they don't want aspirin to be in the system. And they are correct. There certainly are reports showing that if you perform a renal ultrasound-guided renal allograft biopsy within 0 to 3 days of the patient taking aspirin, so the dose I think was 150 milligrams, then there's an increase in major and minor complications from your biopsy compared to 4 to 7 days, etc. So adequate venous outflow, there are 2 things that really is important. The one is the use of femoral catheters for dialysis that can cause a lot of damage, a lot of thrombosis, and make our lives very difficult trying to get a kidney in there. And then the short right renal vein, especially in the living donor, where you couldn't take a little piece of the IVC to do a plasty of the IVC and elongate the right renal vein. In a living donor, you know, as you guys would know, the renal vein, where the confluence with the IVC is very thin walled as well. So these complications, I'm talking about patients who had femoral catheters for long periods of time. It's just a very unpredictable situation. You don't know how prone the patient is going to be to thrombosing their external iliac vein or even their distal IVC. So we prefer to teach not to make use of long-term femoral lines. I mean, many of the patients have to have a temporary catheter for a week or 2. You know, that's something we have to live with. But long-term femoral catheters, although it's a convenient way of dialyzing the patient that doesn't have upper limb access, is something that sooner or later it's going to cause the patient to become non-transplantable. Now, there are ways to get around IVC thrombosis and a few other things. We have never done an orthotopic kidney transplant, but in theory, it is possible. But I think what you need to know is that for every patient that you do this for, that kidney could potentially have been transplanted into someone who would have just needed a straightforward kidney transplant without all the risk. So technically it is possible. The bigger question is the question of how are you going to utilize this resource that you have in your hand. If it's a living donor option, it's slightly different, but deceased donor kidneys, generally to do this kind of technical gymnastics is not great, to try and do it at night, unscheduled, etc. So this is just a picture of a short right renal vein, the vein being extended, and that's the external iliac vein, right renal vein. The extension, sometimes if you have a deceased donor, we use the iliac vessels. If you don't have a deceased donor and it's a living donor transplant, you can take a small little piece of the recipient's internal jugular vein. Alternatively, you can, in theory, also take a little piece of their fistula and put it back together and reperfuse it and extend the vein with that. Urinary leaks are probably, you're supposed to have less than 4% urinary leaks. We used to have quite a few at some stage. We started to make use of double J stents routinely in all transplants, except for a few ones where it was kind of left to the surgeon to decide. We see, I mean, just anecdotally, much less urinary leaks. In my experience, they kind of are 2 different types of leaks, and I'm sure you experience the same in a non-transplant patient profile. The one would be an early leak, so early technical leak that's picked up either through large drain outputs, can be biochemically confirmed perhaps, or it can be on a post-op renogram where you didn't really expect it, but there's a big leak on the renogram post-op day one. Those ones are usually technical and needs to go back to theatre to be repaired. I don't really think there is much of a place to manage a urine leak conservatively in an immunosuppressed patient, although there are certain patients who are extremely complex and where if you have a stent across your anastomosis and if you have a drain in situ, that you potentially could consider it, especially if the patient is not very symptomatic, not tender, doesn't have issues with hyperkalemia, then it's something that you can consider early on. But those would be the only types of patients where I would consider not to go and address it. I'm going to go to, so ureteric stenosis, we find that we are seeing less late stenoses with the use of stents, whether it's, and this is again just anecdotal. Let me just quickly see. So the question for us was to stent or not to stent, and I think this is something that's worth going through in a bit more detail, but and that you can go and have a look at a bit later. So this was a systematic review and meta-analysis on randomized controlled trials, a stent with and without stent in a transplant patient cohort. And the summary of it all is that you can still have the benefit. So as you know, the disadvantage of stents would be to introduce infection or to kind of cause a nidus of infection forming in immunocompromised patients early on. These studies basically show that with using a stent, you avoid the major urological complications. And if you remove it within 10 to 14 days, then you can still have all that benefit without the added disadvantage of the urinary tract infections. So don't think I've got more time. I had 2 case reports that I'm going to skip over. I just want to quickly finish off with this. If you are dealing in your urology practice with a patient with a functioning transplant, kidney transplant, this slide was actually meant for our general surgical colleagues, but I think it's also useful for you guys. I think if you should try and notify the transplant unit the patient is actually currently admitted with you, and just try and get a bit more clinical details and try and be as best you can with communication. But the patients that are less than 6 weeks off their transplant, they generally are still very immunosuppressed because of the induction immunosuppressions that we give them. Anyone that's got sepsis should definitely be notified. The transplant unit should know and should primarily, ideally, be looking after them. If you're adding drugs to the current regimen, because there are a lot of drug interactions, or if you're taking the patient for abdominal surgery or major elective surgery, I think those are the things that, as a transplant unit, you definitely would like to know and see if you can contribute in any way. There are a few immunosuppressives that I'll skip over quickly, and then just know that there are certain infections, opportunistic infections that we have to administer prophylaxis for. So CMV, TB, and PCP are the most common ones. The patients will be on prophylaxis for 6 months to a year. Okay, I think we'll leave questions to a bit later. I think I've already gone over my time.
Thanks a lot, Tinas, for a great talk and overview of transplant, your experience and complications. I think we can quickly address a few questions related to surgery now. Otherwise, towards the end, we tend to rush a bit. Are there any questions for Dr. Tinas Toit regarding surgical aspects and complications? Just a quick question from my side, Chinas. Do you guys ever consider or used to do a biopsy baseline at transplantation?
Thanks, Sam. We perform what we call a time zero biopsy. So on reperfusion, we wait until the kidney is pink. We perhaps do the bladder anastomosis along, and we go back and do a time zero biopsy. But that's only at the moment in clinical trials. We do not do it routinely, and it's something that potentially we should consider. There's certainly you know, a lot that one could potentially you know, gain from comparing a biopsy at time zero and a week later whenever the patient rejects. So it is something that we are discussing and talking about. The issue is that it's not without problems. Our pathology system is under a lot of pressure. So it is something that we will have to discuss with them.
Okay, no, thanks a lot. Yeah, I think we'll just see. We'll probably type questions for the end. I think we can move to the next speaker. Thanks a lot. So the next speaker is the transplant coordinator, Fiona McCurdie, Sister Fiona McCurdie. Also quite privileged to work with her when I was doing my rotation when I was in transplant. And Dr. Toit. Can you start up her slides, please, so she can start.
Dennis, can you put my slides up, please?
Yes, I'm doing that.
Oh, great, thanks.
Can you have I shared them? Let me just see.
Not yet.
Okay, just a moment. Can you see the slides?
Not yet.
Just give me a second.
Okay. Yes.
Okay. Thanks.
Yeah, we haven't. Thanks a lot.
Great, thanks very much. Thank you for including me in this presentation, Sam. Morning, everybody. This is going to be a bit of a downgrade on what Tinus has just been talking about. I'm just going to give you an overview on living and deceased kidney donation here at Recipient and the workup that we do for our recipients and donors. Next slide, please. Just as a background, I thought I'd just give you this picture. I've been working in transplants quite a long time, not quite as long as this graph shows, but just to show you that over the years how things have changed. And we hit our peak in 94, where we did 99 transplants. Unfortunately, we couldn't squeeze in that 100th one before the end of the 31st of December, which was a bit frustrating, but that was our peak. And as you'll see, the numbers did drop over the late 90s and early thousands, and that was not due to us necessarily doing less transplants here, but because there were patients that went to the private sector, which opened up their transplant programs. And in fact, the numbers for the Western Cape haven't gone down that much, but we would have to look at the picture for the entire country to be able to see how numbers have stabilized. Unfortunately, our numbers of deceased donors has not kept up with the need. And so as you can see, our transplants are being backed up by our living donor transplants. And you'll see later on in one of my slides, just showing you the problems we have with our deceased donor program. You can also see right at the end there the devastating effect that COVID had on our transplant program. We're picking up again this year, and hopefully this year will be a reasonable number of transplants. Next slide, please. I'm going to just simply talk about the recipients, then living donors and deceased donors. Next slide. When we talk about recipients, I'm not directly involved with them, but there's a basic process that the recipients will go through to get to their transplants. Patients who are in chronic renal failure are presented to a multidisciplinary team meeting on a Thursday for acceptance onto the transplant program. It's a tough meeting, lots of stress involved, because we have very strict criteria in relating to acceptance on these patients, because we've had a lack of dialysis resources. So for a patient to be accepted onto dialysis, they have to be a transplant candidate. And there are unfortunately a lot of patients that we would like to transplant, but because of the criteria, we are unable to. Once they've been accepted onto the program, tissue typing bloods are sent to the lab with their blood group, their antibody screened, and we then enter them onto our transplant database, which includes all the patients in the province. The patients all compete, in inverted commas, for the kidneys according to time waiting and a few other factors that will give them points on the database. And then as they're waiting for their transplants, they obviously have regular bloods taken and assessments, because basically those patients have to be ready and available for a transplant at any time. So we need to be particularly vigilant so that we don't slip up and have a patient landing up on the table where there's actually a problem and they shouldn't have been called in, and then that kidney that they could have had is getting old while we try and find, and the long cold ischemic time while we try and find a second recipient. Next slide, please. So what do we mean by recipient workup? Well, I've just made a list here. I hope it's clear to folks just what is done with these patients. They're obviously coming in 3 times a week if they're on hemodialysis, and sometimes 2 to 3 monthly if they're on peritoneal dialysis. But depending on the different tests that need to be done, it's 4 to 6 monthly chemistry, so that they can make sure that they are maintained. Everything related to their calciums, vitamin Ds, and their bone disease and so on. 3 monthly hematology is done, and the aim is to maintain an HB between 10 and 12 using erythropoietin. We're very fortunate now to have that, so that we can avoid sensitizing our patients by giving them blood transfusions. I can remember when I started way back, patients would be coming to transplant with relatively high antibodies, and if you looked at their history, they'd had 10, 15, 20 transfusions to try and maintain their HB, and fortunately we're able to avoid that now. 6 monthly virology is done, HIV, Hep B, Hep C. 3 monthly antibody screening bloods are sent to the tissue immunology, and new trays are set up so that if the patient's antibody levels have changed, when a new donor comes along, they are then cross-matched with the new bloods against the donor, rather than using old bloods which may not be having the same antibodies in them. On a monthly basis, the consultants do a ward round to see each and every patient. They're checking their dry weight, their results, their compliance, BMIs, cardiac status. And there are times when patients develop cardiac issues, they're put on hold while those are investigated. The patient may not come back onto the transplant program because that's an issue that's going to make them unsuitable, or they might have a problem with TB after 6 months of treatment, where they're suspended from the list, they get brought back on again. So those monthly ward rounds are essential to make sure that our dialysis population is as healthy as they can be for transplant. The dietitian and the social worker play a very important role in maintaining these patients' health, not just physical health as far as the dietitian is concerned, but their mental health as well. A lot of them struggle with work and financial issues, and that just makes it a tough life even tougher. Our dietitian, Lynette, I'm sure lots of folk know her, has got a fancy new gizmo that is going to be testing their lean body mass and their all sorts of their muscle mass and all sorts of things, and trying to look at what dietetic interventions are going to help to maintain their health and in fact improve their health. And then I've added this at the bottom, phone numbers, one of the most simple things that you wouldn't have thought would be an issue, but trying to get hold of a patient when they've been allocated a kidney is a nightmare for the physician on call. We usually have 2 or 3 phone numbers for a patient on our database, and it can take any number of calls to try and get hold of that patient. And we've had a number of patients that have missed out on a kidney because their phone numbers have been incorrect, they've lost phones and they haven't updated. So part of our responsibility is to remind these patients to give us their new numbers, otherwise they could miss out on a precious kidney. I've also just added as an afterthought COVID vaccination. We decided during the COVID crisis that vaccination would be mandatory for our recipients. There's, as you all know, been a lot of discussion and there's been things on the news about it, but that was the decision, and the patients have all been vaccinated that are waiting for transplant. Next slide, please. I'm moving on from recipients now to look at living kidney donation. And we've had evolving criteria in terms of who can give a kidney as I've worked in the unit over the years. When I started, parents and identical or haploidentical siblings were the only patients, donors that we considered for our patients. We wanted the best result. We felt that it needed to be the closest match, and with the immunosuppression that we had at the time, that was the best options. As time has gone by, we've needed to increase the scope of our living donors due to the lack of deceased donors and the lack of dialysis resources. We want to try and transplant as many people as we can, as well as obviously increased or better immunosuppression. So we added in wider family members, non-identical siblings, grandparents. When we're talking identical, we're talking about tissue typing, not as in everybody wishing that they had a twin. Grandparents, aunts, uncles, and cousins, and so on. As time went by, we looked at unrelated donors, friends, colleagues, neighbors, spouses. Unfortunately, the way our law works, spouses, even if they've been married for 30 years, are still considered unrelated. We'd like one of those regulations to change in our law, but we haven't managed to change that yet. We've moved on even further from that, and we look at using altruistic donors, people who just phone up and offer us their kidney because they'd like to help someone. Kidney paired donation program and domino transplants, which I'll talk about a little bit more now. And then in recent times, we've been doing ABO incompatible and even transplants where there has been some positive cross-matching, but we can manage it with doing preoperative plasmapheresis and so on. Just to go back a step to talk about altruistic donors, I've currently got somebody that I'm about to see. We are very careful to make sure that they are understanding the risks. We use our social worker to help us screen these patients. We certainly have picked up a few over the years where they're not as mentally stable as we'd like them to be a donor, and we've had to gently suggest to them that they're not suitable as a donor. But we have had a couple that have worked through, and one that we were almost going to call in for a cross-match against a particular recipient who looked on paper like they were a match, and then unfortunately the donor developed early onset Parkinson's, so we had to pull out of that. But hopefully we'll be able to use this new patient that has come through. Next slide, please. I mentioned kidney paired exchange or kidney paired donation just now. We have done one triple pair exchange a couple of years back, just before COVID. And this is a principle of if I'm not a match for my sibling and someone else isn't a match for theirs, it might be that the donors can give to the opposite siblings, and we can therefore still transplant the patients. A little bit more complicated when you add extra pairs in, but it can work with a bit of time spent on making sure that all the logistics work out. One of the things that has been emphasized internationally, clearly Europe and America are far in advance in terms of numbers than we are with doing these things. It's always preferable to do the 2 donors at the same time if you're doing a 2-pair exchange. One wouldn't want to do one procurement and transplant and then have the second donor say he withdraws because he's now happy that his recipient has received. that happened in the past, and we clearly want to avoid that happening in our area. Next slide, please. An altruistic donor can actually be the start for what's called a domino transplant. We haven't launched into this as yet. And again, it's a major logistical exercise, but it basically can mean that you can have an endless chain of transplants happening, basing it on trust that a donor whose recipient has already received a kidney will still go on and donate to the next person. And there certainly are chains in America where there's been 50, 60, 70 transplants that have followed over time, all because one person started the process. And that's something that will be very interesting to see if we can get something like that going. It might involve other centers around the country so that we've got a big enough base to try and find good matches, which will also be an interesting process to work through for the future. Next slide, please. When we do the living donor workups, we are basing what we do on an Amsterdam protocol, which is basically international guidelines, which we have adapted slightly into our South African Transplant Society guidelines to make them a little more practical for the South African situation. But basically, it's a standard workup process that we go through for each and every donor with no exceptions. Next slide, please. Unfortunately, this is fairly busy, but it's basically highlighting that we do a full blood screening where we're doing blood group, tissue typing, renal function, liver functions, glucoses, cholesterols, hematology, and virology. We're also looking at albumin creatinine ratios and urine MC and S. If all of that is fine, we get onto the radiology where we do chest x-rays, ECG, we do a renal ultrasound, not just looking at the kidneys, making sure they've got 2 healthy kidneys, but also looking at the rest of the organs in the abdomen, picking up things like gallstones, prostate hypertrophy queries, ovarian issues, and the liver is an important thing as well. We've picked up fatty livers on a number of patients, and we would send those patients on for further assessment with the hepatology team. And it's usually part of a process of where we have to encourage those donors to lose weight and get a bit healthier. And should they do that, they would become suitable. We do split function renograms and isotope GFRs to weed out which is the preferable kidney to take. And together with the results of the CT angio, the surgeons will then make a decision as to which kidney they want. The CT angio is obviously being done to pick up multiple vessels and see which is the easier and safer kidney to remove. The physician will see the patient and just make sure that what we see on paper ties up with what we're seeing, make sure that the patient is fully informed about all the risks of surgery, etc. The social worker does a similar thing. Glucose tolerance tests are done for patients who've got a first-degree relative with diabetes. Any issues with blood pressure monitoring, we will, with the blood pressure, we'll do 24-hour monitor, lung function tests if we're concerned, if it's a smoker or there's a history of asthma, pap smears and mammograms, PSAs and PRs if necessary. And just to say that the international guidelines tell us that it's safe to use a donor whose blood pressure is well controlled on 3 agents. We've brought that down and said 2 agents, but we're still pretty strict. We might actually send the patient for an echo and that sort of thing as well, and just make sure that the patient is healthy enough to be donating. We haven't had any disasters with our donors. I think it's because we're careful, we're conservative, and we don't take shortcuts and chances. Next slide, please. Explaining the operative, perioperative, and long-term risks. The patients, I think, get a bit tired, or the donors, should I say, get a bit tired of hearing about them, but it is our responsibility to talk to them about those issues. We've also got to make sure that there's no psychological issues, there's no coercion, not feeling forced into it, concerned about other family responsibilities. And of course, a donor who's employed, especially if they're in a lower level job, they might be concerned about finances, and we need to talk to their employers to make sure that they're not penalized for taking some time off to donate the kidney. Common issues that we pick up with our living donors is obesity. That's one of the biggest issues we have. We are a little bit generous in some ways, in that we say that 30 is the BMI cutoff. And some of those patients are not slim, but we are strict with that. I had a donor yesterday who came in most upset because I said he wasn't really suitable. His BMI was 41. He felt that he would lose that weight in a month or two and then he would be suitable. Clearly that isn't going to happen, and we'll just have to find another family member for his daughter. Hypertension, we're picking an awful lot of it up, and we monitor. A lot of the patients get referred for follow-up. And a common issue we have is, although we ask the patients to be honest, and we're quite happy if they do change their minds or whatever, they just disappear, don't answer WhatsApps, and they're telling us in their unspoken way that they've changed their minds and they don't want to donate. Less common problems, employment issues do come up, but we usually manage to explain to the employers what a wonderful thing it is for the donation, and we can get around those issues. We have picked up a few HIV positive patients unexpectedly, and we refer those patients on to the appropriate channels. We've picked up a few unexpected cancers, and there have been a number of gynae issues over time. The donors are actually grateful. Problems are picked up that they didn't know about. Disappointing for the recipient, but it's overall not a disaster in the bigger picture if we've managed to save the health of that donor. Next slide, please. Just to say that if we want to do an unrelated transplant, or the patients are foreigners, we have to go through the Ministerial Advisory Committee for Transplants to get permission to do the transplants. It unfortunately adds time to the workup, but it's a non-negotiable, and the transplant has to be signed off by the Minister of Health before we can do it. Tinus has already done a whole lot of slides talking about the laparoscopic nephrectomies, just to say that our donors are usually discharged on day 4 or 5. We see them at the clinic 4 months later and then annually, and we do blood pressure, ELEX, creatinine, weight, albumin creatinine ratio, and just make sure that they're okay. We did see a few unfortunate complications for patients who had the open surgery, and that was obviously the pain. I didn't have too much sympathy for the patients who were smokers and were coughing, but the pain of that cut in the rib region was not nice. Hernias, we've had in inverted commas, apparently they can't really be called hernias, but from those wounds, there have been a few patients who have developed swellings and so on at the areas. And we had a few patients at the time we were doing epidurals, and a few donors did have quite severe epidural headaches. And in the long term, seeing the patients as the years go by, a few have developed hypertension as they've gotten older, and we're treating that and monitoring. And then there are some patients who, no matter how much we beg them not to put on weight and to maintain their healthy lifestyle, they do put it on. Next slide, please. Similar thing with deceased donors, moving on to that. Our criteria have changed over the years. Ideal donors were the talk of the day when I started, where you really only had young, fit, healthy donors that we were using. We've had to expand our criteria again. It's an international response because there's an increased number of donors, patients on waiting lists. We now look at older patients. We look at patients whose creatinines are a little bit higher than they used to be, patients who were a little bit less stable, patients who have comorbidities that would worried us in the past, and we're now saying we can manage them depending on the situation. Hopefully you all know that we did HIV to HIV programs from 2008 with well over 50 successful transplants. We do donation after circulatory death, which I'll go into a little bit more. And just recently we did our first Hep B pos to Hep B pos, and we've talked about using Hep C positive donors for negative recipients with a protocol that's been drawn up by the hepatologist. Next slide, please. Our deceased donors, just for background, majority of them have been trauma cases over the years, although we do get a lot of medical referrals now, far more than we used to. Intracranial hemorrhages, overdoses, hypoxias. The tumor meningitis referrals always cause a bit of discussion, and one has to take each case on its merits and look at the background. Obviously, a young trauma donor is going to be a better donor in the sense that they've been fit and healthy previously, whereas a medical donor might not have. but we're always very grateful for whichever donors we do receive in terms of referrals. Brain death is the starting process for our donors after brain death, and we have to have a known cause. There's a series of tests that need to be done with preconditions. The transplant team clearly can't be involved in that. And just to say that forensic cases can be donors. The state pathologist's consent is required, but we are very used to doing that. They're used to dealing with us, and it's a given that they say yes to us. We really don't have problems with that. Next slide, please. Just to show you for interest's sake, that's the paperwork that makes it very easy for the doctors to do the brain death tests. Next slide. A deceased donor, just the process, obviously they need to be certified, or for a DCD, which I'll talk about, there's a decision to withdraw treatment. We need to get consent for organ donation from the family. We also then have to get consent from medical supes and state pathologists. We send off chemistry, hematology, virology, tissue immunology, UPCRs, and ABGs to get a full picture of the patient's condition. And as the night goes by, because we usually manage the patients overnight for an 8 o'clock theatre start, we must maintain the hemodynamic stability. The patients can often be fluid deplete when we see them. They're cold. We need to warm them up. We need to fill them up. Try and wean the inotropes while we're giving the fluids to try and get a good balance. We give steroids. Many of the donors overnight develop diabetes insipidus. We give them DDAVP and obviously potassium replacement once they've lost it in the urine. Sodium's going up is not great for the effect that it has on the liver and stability. We try and replace with water down the nasogastric tube to try and get that settled. And we do regular ABGs. We do an ECG, X-ray, and so on to make sure that everything is looking good. Organs are allocated according to blood group, age, height and weight comes into it for the thoracic organs and the liver. And the cause of death, current condition, and the blood results are all the important factors for deciding who the recipients are. Tissue typing plays a big role in the allocation of the kidneys. And then we usually go for an 8 a.m. procurement, do the transplants, and then it's also the donor's responsibility, coordinator's responsibility to follow up with the donor family, make sure that they feel appreciated, and just assist them in dealing with things like postmortems, etc. Excuse me. Raised creatinine is sometimes an issue, and we'll have teams saying, oh, you can't use these kidneys, the patient's creatinine has gone up. One has to look at it in the bigger picture, check the patient's baseline creatinine, the trend as the patient has been in the unit, and then assess response to fluid management and lowering of inotropes, etc. And if we've managed to halt the increase of the creatinine, and we've managed to either get a stable status or a turnaround, those kidneys will probably be fine. Probably have a bit of ATN, but will be usable. Next slide, please. I'm not going to talk about DCDs, just to say, because we've run out of time really, but it's a non-heart beating donor, and it's another way of us trying to get more donors. We've had a program going since about 2008 as well, and we've certainly increased our transplant numbers by using these donors who were not brain dead, but we could follow up with after doing a controlled arrest. Those kidneys also are more likely to have ATN, but the long-term results are better. Next slide. Important points related to our program is just that we still have poor referral of donors by our colleagues, which does remain a problem. Sometimes it's due to lack of resources, but unfortunately, in certain instances, it's lack of will or interest. There is a possibility of a required referral policy being brought in, maybe starting here and becoming national, but that is one of the ways that we might look at this problem. It's how other countries deal with it. And then just to say, poor consent rates from families, it's a talk all on their own, talking about religion and culture issues, lack of insight, trying to find families, transport, finances, all sorts of things play a huge role in our poor consent rate in the state sector. The private sector has a far better consent rate. Next slide, please. I think it's the conclusion. Yes, just to say it's been a quick overview. I hope that you can have a better understanding of what we're working with. We've got pressure on our dialysis resources. We've got growing waiting lists. We need to expand and have expanded our criteria for our donor groups. bearing in mind that we can never, ever compromise on the health and safety of our donors. I hope I've given you the information that Sam wanted you to get. I'm going to change tack slightly here. And the next slide is a challenge from me to all of you. Thank you for listening to me.
Thanks a lot, Fiona, for an excellent talk on the workup of a patient organ donation, the donor and the recipient. And because I know you've got so much experience in this. Like I said, I remember when I was working with you when I was there, such an an honor to be working with people so experienced in this field, and I quite enjoyed it. Yeah, no, thanks. Are there any questions on the floor for Fiona or Tinus? Okay. Right, I think I'm not seeing any questions on the floor. Just one question from my side, Fiona. How has COVID affected, the waiting lists in, in kidney transportation or in any form of transportation? Because I saw that the big numbers that you're showing in the beginning, that you've always strived to obviously do a lot of transplants per annum, because I think we know very well how much this really impacts on the sort of like on the patients and their social lives and stuff. Because if they get to be on dialysis, they have to come 3 times a week. I've seen patients crying when they are called to come for transplant when I was there, because they get to work at least because they don't get to come to the hospital 3 times a week on dialysis. And how has COVID really impacted on the sense?
Okay, so obviously during the actual waves, we just didn't get referrals at all because the hospital was not able to do transplants at the time of the COVID crisis. Sorry, and obviously it was not particularly safe for us to be transplanting patients and immunocompromising them, sending them out into the community. We haven't lost a couple of the referrals we have had. We haven't lost many when the donors have turned out to be positive. So that's been reassuring, because if we get a deceased donor, we do test them, and if they're positive, we don't use them. Although the feeling is that we can probably change that now. Yeah, it's just caused a huge backlog, and it's actually a headache for the patients who are not even getting onto the program because we're not transplanting other patients off. That's where it's hitting, is in the assessment meetings where they've got a good patient who's suitable for the program, but in fact there's no space. So that's the throughput is where it's actually hit us badly.
Right, thank you so much. Any last comments, Tinus, from your side?
No, I just want to thank you for inviting us to this, and yeah, thanks Fiona for your talk. And yeah, we are always available if there are any questions or anything after a talk like this. So yeah, you can contact us on email if there are anything that you would like to specifically ask or discuss.
Yeah, no, thanks a lot. I must say I quite enjoyed the procurement. I saw this nice diagram you showed earlier, because it's very nice, sort of like anatomy wonders of procurement. I enjoyed the procurement more than the donation. Yeah. But anyways.
Yeah, I think it's maybe worthwhile for all the urology registrars. I mean, it gives you a beautiful view of the anatomy, something you won't see in any other operation. So if there's a deceased donor being booked on your board wherever you work, try and stick your nose in and go and ask questions and try and get a glimpse of the anatomy, because it really is special to see.
Right, once again, thanks a lot to Dr. Toit and Sister McCurdie for giving excellent presentations and overviews on transplant and the services they're offering to our patients in the Western Cape and beyond. Thank you so much to everyone who's logged in for this special session this morning. We'll see you guys next week.
Thank you.
Thanks, Sam.